Hello. Good evening, friends. A warm welcome on behalf of MIDAS Clinical meeting. So, it's indeed a great pleasure that we have so interesting cases this time also. Would like to start within 5 minutes or so. Today, we are fortunate to have with us chairpersons for today's clinical meeting. May I invite Dr. B.S. Gedam. B.S. Gedam, sir, is a professor of surgery at Lata Mangeshkar Hospital. He doesn't require any introduction, but he's my classmate. More than that, he's my classmate and a very surgeon, renowned teacher, academician, and teacher. I never had an opportunity to praise him, so I thought that this is the best occasion. So, Dr. Ghansham Chude is another consulting. Please join the dais. Vaibhav Banait and Dr. Manoj Vevare. Dr. Amit Agrawal informs me that he's down with probably chikungunya, post-viral fever and all, weakness. And Dr. Abhiram probably would be joining shortly. I also have a pleasure in inviting our online chairpersons, Dr. Ajay Kumar, consultant gastroenterologist, again a very close friend, King of Delhi. I always call him like a King of Delhi. Whenever there are any referrals related to Delhi, they go to Dr. Ajay Kumar. He is in Max Hospital. I'm right, Ajay? Then we have Dr. Venkata Astinlatala from consultant John Hopkins Hospital. Saurabh would probably introduce him. Saurabh is joining shortly. And Dr. Nikhil Sonthalia is a consultant gastroenterologist. So, with this, I hand over the dais to the chairpersons for initiation of clinical meeting. Over to you, please. Can start with first case. Dr. Samir Herbert has also come.
First speaker is Dr. Samir Arbet and Bhushan Baware. He'll be talking on combined interventional pulmonology and endoscopy to successfully treat two cases. So I hand over mic to chairperson, speakers. Over to speaker.
Thank you, sir. Good evening, all to chairpersons and all the delegates here. So, please bear with this case. It's a very challenging case, what I am going to present in this thing, and always required for your guidance for anything we cannot done best for this patient. So, yes. So, this is a very young lady, 36-year-old female. She was diagnosed a year back with a case of an advanced carcinoma right breast, and was since then was in follow-up with TMH on oral chemotherapy. Over time, the patient continued to have oral chemotherapy, but in February 24th, she started to having dysphagia. She was evaluated in Jabalpur Hospital and found to that she on endoscopy, she had an upper 1/3 esophageal stricture. Etiology of stricture was really not unknown that time. Cross-section imaging, no extrinsic mass. And that time, the endoscopist didn't feel anything to take a biopsy, but patient underwent a dilatation and on 22nd of February 2024, and post-dilatation, he had a massive perforation. Esophageal rick, so much so that it causes a right lung empyema. Patient went into sepsis, septic shock, and was managed at that hospital with the intercostal drainage placed. So with this background history, patient reported MIDAS on 3rd of March, and he or she was really sick, admitted in ICU. Our fantastic ICU team, Dr. Doke, Dr. Prasad, Dr. Mugdha, Dr. Jayant, all were there to manage this patient. She was really hypoxic, sepsis, and was having a shock on single inotropic support, and also having a purulent discharge from an ICD. On that moment, after 3-4 days of hospitalization on ICU management with broad spectrum antibiotic, finally we need to take out the source of the patient. As you can see on X-ray, there was a very light consolidation with the ICD. Hope so you can able to see or not. The procal was elevated on blood picture. So we take an opinion of thoracoscopic surgeon and pulmonologist. And after stabilization, we decided to underwent on thoracoscopy and decortication of loculated collection, and feeding FJ was performed. So though I didn't have a proper video of it, but this was the setting. Like FJ was performed, thoracotomy, collection was taken care of, and thereafter, post-op, she recovered from this sepsis. So this was the first hospitalization, almost considering of 12 to 15 days, for stabilizing the patient from post-esophageal dilatation perforation. We managed this patient. So on 2nd of admission, patient came really well. His nutrition status was well. Now this time, I think after the ICD was in situ, the FJ was placed. We perform an endoscopy. As you can see on endoscopy, there was a rent or a opening. There was something was there on the upper esophagus, just about 15 to 18 centimeter from esophagus. And thereafter, I can able to advance. This was a scope. Sorry to say, it's a pediatric scope what I advanced. So pediatric scope, I have just advanced in one of the opening, and I started to go in fluoroscopy. Okay, I can see there is something at around it went from 30 to 30 centimeter. I was saying it may be an very bad esophagus stricture. So I tried to do advance of guide wire, but guide wire is not at all going further deep into it. So I thought it may not be this is not a, so you can see a tunnel has been formed. I thought it is a esophagus or what. So basically it was more a mediastinum, which I entered to that perforation. So there almost we given up. This was around 30 minutes that I did a procedure. And then I was searching that, okay, let me try from another hole, which is seeing from upstairs. You can see this is a rent. And then I make my big wheel down, and I can see one more opening really upstairs at around 12 o'clock, 1 o'clock position. And yes, I can see this opening was there, a small opening. Through the opening, again, I advance a guide wire, and this time the guide wire very nicely coiled into the stomach. I can not get a fluoroscopic image. Then I went a cannula over it, and then I thought, okay, I have got something opening. I will do a risky dilatation. I will just a small. So I perform a Savary-Gillard dilator, and up to 11 mm. This time I can advance the pediatric scope across the stricture. We can see a distal ischus was fantastic. Almost mid-esophagus was also normal. So it was a very short stricture, around 15 to 18 centimeter, around 2 to 3 centimeter below the upper esophageal sphincter, as you can see here. Yes, so this was a record. So I dilated the stricture. I can see a rent out of there, which is not very infected. And post-dilatation, patient was stable. And she was doing well. And for maintaining that patency of that opening of stricture, I prophylactically put a nasogastric tube, just to make sure that my next dilatation, I should make that that hole should not be like completely closed, as I found difficulty in the first dilatation. So in third admission, patient came again a very stable patient. FJ feeding was going on. She was off her chemotherapy. It was just just a short 2 centimeter stricture. So there was two things in my mind: whether should I continue with the dilatation process with a bag history that patient has already perforated by dilatation, it's a very risky, or should I put a SEMS? But SEMS was really difficult because it is just around 2-3 centimeter esophagus, so it was a really challenging. But I thought, we discussed with our internal teams, Dr. Mukeva sir, Saurabh sir, we all came together for this case, and we thought, okay, we can do something novel. We can do some cervical stent. We can put some fully covered cervical stent, which can take care of this perforation, and also because of an short proximal head design, that may prevent a vocal cord damage, and the silicone covering reduces the risk of tumor ingrowth. And we thought that this stent may work. So we thought it is we procured this stent from it was a Taung stent, and it was around 18 mm in diameter and around length of 8 centimeter. And then we decided, after counseling with the relatives, okay, we may go forward if you maintain a patency of this. So yes, this time, as you can see, that the tube was keeping the patency of that stricture open. I removed this nasogastric tube, and it was around 2 centimeter below the esophageal sphincter. So I have to be very precautious about the thing. So I can see the rent also was seen. The opening also I can able to see here. And also one background mind was also going that what is the etiology of stricture? Why the patient has developed stricture? So I take a biopsy to make sure that are we dealing with some recurrence of disease or something what there, or recurrence means like some there is some tumor infiltration or there. So I take a biopsy from that also. Just get a forward for it. Yeah, so you can see I taken a biopsy from a stricture. And thereafter, I keep the guide wire in situ, and with the fluoroscopic guidance, yes, I can put a metallic guide wire. And this was a proximal nitty stent what I see. So I can able after passing the stent, it was an 18 mm or on 6 to 8 mm delivery system is there. So under fluoroscopic guidance, with a very appropriate position, I can see and just deploy the stent just below the upper ileal sphincter. I can see the marker was there with a good use of fluoroscopy. I deployed the stent out there. So it was a very combined approach of sort of handling the scope. I was putting a stent. Fluoroscopy guidance was also there. I put my third pediatric scope was also there so that the stent should not be coming very up or very down from that. But successfully, at that point, the technical success what we achieved that we put a fully covered stents. So post-SIMS barium was also done, which also seen that there is no leakage. The contrast was very nicely flowing below the stent and into the stomach. And the biopsy which was done by Dr. Prajakta, hardly there was no tumor cell, right, Prajakta? So it was a completely, this was a mild non-specific inflammation that biopsy report has came. And as you can see, the barium is very nicely flowing through the stem and into the going into the stomach, and the perforation was also taken care of. So in this time, the patient was doing very well. So after all, I can see around 40 days, she was very nicely taking semi-solid food. But after 40 days, patient again arrived with us with an history of breathlessness. She was also having some abnormal sounds, which can see stridor type of symptoms, and again difficulty in getting deglutition. So this was so much so that the hypoxia she has to prophylactically intubate in our ICU. And that time during intubation, our intensivist thought there is some tracheal compression is also going on. So stent may have caused some tracheal compression and causing such type of stridor and breathlessness. So we have to immediately on the table, we have to really remove that fully covered stems. So one of the novelty of this stem is that we can just pull out some blue strength. We can see some thread out there. You can see there is some tumor ingrowth both from a proximal and distal end also has been there, taken there. So I just pick up this rat tooth forceps and just pull up that thread. Just pick up the thread and just remove that stent. Yes. So after removing the stent, again, this was all, this time we can go with a gastroscope at least. And we can see a tumor in growth. The stricture is really open up, not like as I wanted to be. Completely, the scope was really not going very deep below it. But we can see a tumor, more of a tumor or some tissue ingrowth which is found both at the proximal and distal end of the stent. So immediately the patient saturation was starting to improve. Patient was really doing well post removaling of the stent. But one issue was there that we did a post-SIMS barium. As you can see, there was really a persistent of leakage. Hope you can able to see that contrast is really flowing, and some of the contrast is leaking into the mediastinium. So there is something, a minor thing is still going on for this patient. So that at that time, after 3-4 admission, patient we has a persistent more of a stricture which has partly opened up. There is a persistent tracheal fistula. Concerned relatives, malignancies also on the card. The CA breast is also there. And definitely for all this, for procuring a cost. So we hope that Dr. Arbas. So this time we take a Dr. Arbas. Yes. So we take an interventional pulmonologist opinion. Here we thought that, okay, if the esophageal stent is knocked and there is a persistent fistula, can we have some opinion of interventional pulmonologist and he can guide us for putting some stenting or not? Hope he will procure from. Do we have video? Actually, you want to combine it? But you do. Acha. Sir is saying that let you complete all the thing and I can at the end of it. It's okay, sir? He want to do it on the later date so that he can do all the things. So okay, what we did, we involved Dr. Arbat, and Dr. Arbat said, and very successfully he deployed a stent into trachea, very nice, very nicely. And post tracheal intubation, patient was really extubated. Patient was stable. So this time, after stabilization, removing from ICU, the UHG test and 2D echo performed with suggestion of moderate pericardial effusion. So this time, the moderate pericardial effusion, which was tapped by our cardiologist, and this time the cell fluid positive or malignant cell. So now, accordingly, it is an stage 4 CA breast. The fluid, the pericardial effusion, which is positive for cytology. So medical opinion, oncologist opinion was sought, and there was no active lesion except for the pericardial effusion. But still on the classification, it goes into stage 4 disease. As for a medical oncologist, required a further newer chemotherapy, and the patient was already follow up with TMH. They want to request to go into TMH and give a further treatment. So post tracheal stenting, I can see the yes, still you can see that there is contrast. The contrast still going into that way, into and opassifying the bronchus. So it was not really thing that has worked for this patient. So this time the patient just recently last month came back with a tracheal seating. He's comfortable. Now we thought, okay, there is no scope for any. At least at that moment of time, we thought it is better to do some, because oral therapy is on the card. So this time we just put a peg for this patient. Endoscopy, I myself did a peg. The endoscopy was very tight stricture. My pediatric scope only has to advance just to guide us for putting a peg. We went a peg for this patient. Now patient is under a medical oncologist at TMH Mumbai, and we thought that we can reassess or will come some with some endoscopic treatment considering a stage 4 poor prognostic patient. So we thought that this is how the patient last admission, and this is how we manage this patient for this patient. So still the stricture is out there, fistula is there, but this tracheal stenting, usual stenting has worked for us. But still, I think so the stricture is more about us in a same line. So this is how we manage this patient, and still we thought that with some novel endoscopic therapy will work for this patient or not. Thank you. So, yeah. Sir, let me allow. I'll complete the second case also, sir. Sure. Continue. So yes, sir, this is another short case of 64-year-old male with he's also a diagnosed case of he's a diagnosed case of carcinoma esophagus, stage 4 disease. He was on radiation. He has already received 6 cycles of chemotherapy and 28 cycles of radiotherapy till August 23. Then after he was on immunotherapy with nivolumab. From January 24 this year, he again started to have a progressive dysphagia, shortness of breath, and hoarseness of voice with a weight loss of 10 kg. Outside, again evaluated, found to have a stricture in the esophagus, query recurrence, query radiation stricture. Twice underwent dilatation outside. No biopsy specimen was there, and patient was dilated 12 up to 11 mm in April 24. And now patient has came here with a more about persistent dysphagia, and with a reference that patient has a radiation stricture and may require a further session of dilatation. So, so the patient was came to MIDAS on 1st of May 24 with the outside CT films, which was reviewed, which was the pictures quality was not there. We suggested a very long stricture in the mid esophagus with a suspected tracheal compression. Though this tracheal compression thing came on the later part, it was not reported on the CT. It was not reported when we reviewed with your radiologist. We thought there is also a compression because of the growth as causing tracheal compression. So I did an endoscopy. On endoscopy around 18 to 20 centimeter, I can able to see this is a post dilatation. First of all, I also dilate the first thing. So I dilated with just a 9 to 11 mm Savary-Gillard dilator. And post dilator, what I found, it was not filing. The consistency was very soft while my dilator was going on. I'm suspecting this is not a radiation stricture what I'm dealing with. So after just a small dilatation, I just pass an endoscope. And endoscope, what I said that it was a more about not a radiation, it was an entire tumor growth is there. There is nothing like a stricture what I able to found here. So this was a long stricture measuring starting from 25 centimeter to around 32 centimeter with distal esophagus spared. As you can see, what I can say, distal esophagus completely spared. I can enter into the stomach from that. It's also a pediatric scope that comes to rescue for us. And thereafter, I start withdrawing the scope. And here the growth was started. This was distal end around, I can remember, 30 centimeter. And it was an entire tumor. It was a more about tumor only. There's a large ulcerated growth, as you can see. So it was not a radiation stricture which the patient has referred to us. And it has found many times that we can found such type of thing. So biopsy was taken. Yes. Okay, fast forward for you. Yeah. So post dilatation, it was more about recurrence of carcinoma. So at that time of moment, 64-year-old male, poor, frail patient, we advise for a patient to put an SEMS. Relatives was cancelled regarding the need of tracheal stenting. In the case that we put a esophageal stent in already tracheal compromise, it may develop a stridor and may require a tracheal stenting for the same. So when this time patient was really concerned on that time, but now this time patient came around 20 days after the OPD, and this time the patient come with a fever, cough, and breathlessness. And this time the patient was really septic. He has developed a pneumonia. There is also development of an fistula now, we can see from this barium swallow. So barium swallow, there is a long segment luminal narrowing from proximal to mid-esophagus can seen. Fistulous tract was seen from mid-esophagus to right bronchus. And there is also some aspiration which is directly going from a laryngo, from upper sphincter or more a post-recurrent junction, directly coming back into the mouth and going into the bronchus. So Bowel, this time I'll just make sure that we involved our intervention pulmonologist because now the options remain for us to stabilize the patient with antibiotics. Good initially. Taken an intervention pulmonologist opinion to make sure that if you put some stenting, can you do some bronchoscopy prior to make sure that whether this compression, how severe is the tracheal compression from your bronchoscopy. So we'll go in this case, he will going to show us. So during this bronchoscopic video, he also sent a bowel fluid, which also came positive for malignancy. So challenges for this patient during that moment of time, that patient was really a septic patient, poor nutritional status, patient has a pneumonia. He has a recurrence of CA esophagus. Now he has also a trachea, which was not on the first OPD admission. Now he has developed a fistula, and he is also on direct laryngoscopy, which we found he has also developed a right vocal cord palsy. So lot of issues were there at that moment of time. And now the options, what we thought, okay, with a limited lifespan for this patient, can we just put a nasogastric tube, PEG tube, or we can do the patient really requesting, can we do some endoscopic so that he doesn't want something, an endoscopic technique. So we really, again, we discuss in our, with our team, can we really come up with an idea of putting both esophageal stent and tracheal stent at the same time. So, this was a thing that we counseled the relative regarding both the ups and downs of the procedure, whether we can successfully deploy it. We had a view that can we put first esophageal SEMS and thereafter put a tracheal stem, but Dr. Mukiwar sir come into the picture that sometime putting of the esophageal stem, the trachea becomes so much compromised that sometime putting a tracheal stem by intervention pulmonologist is made difficult. So can we put on a simultaneously, immediately on the same table, once Dr. Arbat sir will do a tracheal stenting and simultaneously we will do an esophageal stenting. So we consulted the relative regarding the same thing, and we have also reviewed our literature. So we found a nice literature in the Journal of Medicine, where they have really done such type of works of combined airway and esophageal stenting implantation for any malignant tracheoesophageal fistula and esophageal disease. So what they found that the technical success is around more than 95%. With the most common complication of the esophageal stenting is also stent migration, which in all the patient they migrated putting another stent, and also another similarly by an tracheal restenosis also there, which was the most common complication of an airway stenting. So in that study, what I gone into an characteristic, simultaneous implantation was done only in six patients out of 35 patients. So most common they had done that first they put a esophageal, first they had done a tracheal stenting. Thereafter, on the gap of around 2 weeks, they have put an esophageal stenting. But this was a thing that they also they had done a simultaneous stenting also. So we thought that okay, in this they concluded that combined airway and esophageal stent implantation under guidance of local anesthesia is very safe and effective. So with this strong literature effect, we thought okay, we can involve intervention pulmonologist, and he will in few minutes he'll showing that he had placed an intervention, but he has put a YSMs, what he going to speak on. So on the same table, I sorry, we can't get a procure a video of it, sir, because often that we get video gets corrupted on that day. So I did a esophageal stenting. It was not an easy stenting. So after putting a tracheal stent by Dr. Arbat, I found that the opening was much more difficult for me. So I with a very mere difficulty, I can able to find an esophageal opening, get a wide wire, and somehow with a normal, this was a Cook stent what I put. We have put a fully covered stent at the same time. So on the same table, the procedure lasted around 25 to 30 minutes. He put an tracheal stent, and I on the same table I put an esophageal stent. Post stent X-ray chest registry of very nicely the stents where the tracheal stent was very in situ. Esophageal stent was also, so patient was advised to start a liquid diet, but again patient has started liquid diet. Patient start again to have some aspiration. So post procedure barium registry of more a mild regurgitation, maybe secondary to partially expanded stent. So this time I went inside, I dilated the upstream end of a esophageal balloon, and post dilatation, yes, patient was doing relatively well, started on liquid diet, was discharged in stable condition, and advised for a very close follow-up for recurrence of dysphagia or a persistent regurgitation. Thank you. Thank you. Let Dr. Arbat sir complete the case and then we can test.
Very good evening, everyone. Most of the details of the case has already been presented. I'll be taking over the part of stenting and the pulmonology aspect.
I think till Dr. Samir adjusts, there are few comments which I would like to make. Are you ready? So one is always, it should be the lesson that when you want to put the ACMS in esophageal stenting, always look at the trachea, because we had the first instance of putting ACMS followed by the stridor of the patient. The patient was in ICU, had to be intubated. And then, getting a tracheal stent is not easy. This time when we planned for a tracheal stent, we had to order and get it from Hyderabad. And in spite of the phone call, it took about 3 to 4 days for the stent to come. So in emergency, you are stuck. So it's always better because the patient's life can be at stake. That is number one. Second is the choice of stent has to be there, because each stent has a different expansile force. So whether you should choose Ultraflex, which has a very less tensile force. If the tracheal stent is having a higher force, radial force, then probably the esophageal stent can get compromised and the dysphagia will be there. So choice of stent is also very important, and one has to balance between the two, that they should be, complementing to each other.
Thank you, sir. So I'll be presenting this part of combined interventional pulmonology and endoscopy for these two cases. So when it comes to stenting, as Sir said, with the great playwright William Shakespeare, there was a saying that to be or not to be is the question. And when it comes to tracheal stenting or esophagus, to stent or not to stent is the major question. So this is the first case that Dr. Bhushan has already discussed. As you can see, this patient presented with tracheoesophageal fistula, and we went ahead with a bronchoscopy. And here you can see that this is how the trachea looks from inside. On your 7 o'clock, you can see this is the tracheoesophageal fistula, which is present over here, and this was the site which was causing problem to this particular patient. So in this particular patient, since the site and the pathology was at the upper 1/3 of trachea, we plan to go ahead with a straight stent. So the patient was intubated with a rigid bronchoscope. So the rigid bronchoscope allows you easy entry and exit, and the patient can be ventilated throughout the procedure. And a fully covered tracheal self-expanding metallic stent was deployed under fluoroscopy guidance. And eventually the patient was extubated with symptomatic relief in cough. So this is the fluoroscopy image of the stent. Here you can see this is the tracheal stent, which has now completely covered the fistulous opening. This is the proximal end of the trachea. Now coming to the second case, this gentleman had this CT scan. Here if you can appreciate, the tracheal lumen is majorly compromised. Similarly, you can see here the tracheal lumen is compromised over here. And this was a cause for the patient's stridor and breathing difficulty. So we went ahead with the rigid bronchoscopy and a Y stent deployment. So this is the video for how the Y stent is deployed. This is a relatively fast forward video. So here you can see there is a right and the left limb for the main bronchus, and this is the tracheal limb, which is now given the patency for the trachea. So this is the bronchoscopic video for the same. What you can appreciate on the right is the right main bronchus and right bronchial tree. This is the left main bronchus. Now the trachea is completely patent, and whatever external compression was there with the mass has now been completely negated with this Y stent. So this was followed by the esophageal stenting. Here you can see this is the tracheal stent, and this is the fluoroscopy image after both the stenting took place in the same setting. So when it comes to tracheal stenting, there are two types of stents. One is the metallic stent, and then there are silicone stents. The metallic stents are easier to place. They can adapt to the irregular anatomy, which might be caused because of any malignant growth. There is a possible increased risk of infection, and these are mostly reserved for malignant pathologies. Relatively, the silicone stents are difficult to put but easy to remove. They are customizable at the procedure time. You can cut and shape the stent as you want. They require a stent deployer unit. There is a high risk of granulation, but they are mostly used for benign pathologies because they are very easy to remove and you can come out with the stent. So when it comes to indication of airway stenting in benign diseases, it's post-tuberculosis or post-infectious stenosis, patients with post-intubation tracheal stenosis, which is one of the most common causes, patients with bronchomalacia or benign tracheoesophageal fistula. And coming to malignant airways, there is external compression, any endobronchial tumor, extrinsic compression, any mixed endobronchial and extrinsic compression, as you can see these images, or patients with malignant esophageal fistula. So this is post-intubation tracheal stenosis. Here you can see the trachea is completely stenosed and there's a incision given and followed by stenting. And in this particular case, this was a post-tuberculous stenosis wherein a Y stent was deployed. Coming to malignancy, here you can see there is an external compression into the trachea. The tracheal lumen is compromised. So metallic stent is been put over here. And this is a image just to explain you how a tracheoesophageal fistula can be covered by both stents at the same time. Now, there are certain contraindications. So, patients who are unfit for general anesthesia, patients who are allergic to stent material, and in certain cases where there is no sense in deploying the stent when the distal part of the lung is not retrievable or you cannot save the lung at all. And there are also relative contraindications when there is no good outcome. So, if you are seeing that the patient's overall quality of life is going to be compromised, or the patient's chances of survival are less than 2 months, it's better you don't go ahead with the tracheal stenting because you will cause more trouble to the patient, or in cases when there are increased risk of complications. So the take-home message from pulmonology point of view is that patients with esophageal cancer might require airway stent for complications which include esophageal fistula, airway compression, or both fistula and compression. Often with the esophageal stent put first, there might be tumor-related necrosis, ulceration, there might be radiation-induced esophagitis, and there can be pressure necrosis from the esophageal stent, which is now putting pressure on the tracheal stent. So these are the cases where you can put a tracheal stent. And combined stenting of both airway and esophageal is very useful when it comes to the palliative treatment for patients of esophageal cancer or patients with end-stage disease. So dual stenting in trachea and esophagus has shown better improvement in the patient's quality of life and dyspnea grading also. And there are some centers which have chosen a proactive method of first going with dual stenting rather than waiting for the complication post esophageal or post tracheal stenting. So I'm thankful to Mukhevar sir and team, and thankful for the OT team of MIDAS, who was very much instrumental in the successful deployment of these stents. Thank you. I'm ready to take any questions. Both of us are here.
Congratulations, Bhushan and Samir. My question, the second case, you said patient had a poor functional status. Patient had advanced malignancy with a recurrence. Patient required esophageal as well as tracheal stenting. How much survival benefit did you anticipate before taking such procedure? Or in other words, when would you like to say no to the patient when such patient is encountered?
Right, sir. You're asking a very theoretical question. If you see a life expectancy of more than 3 months, a 3 months life expectancy, if you are giving for the patient, 3 months, yes, stenting is a good option for the patient. If a patient have a good financial problem, no financial problem. So if you are expecting a life expectancy of 1 month, 1 month, yes, definitely the most cost-effective approach is putting just an RT and leave the patient. No approach, sir.
So how do you
given
assess,
both the option?
how do you assess whether he has 3 months to live or 1 month to live?
Depending on, sir. First, we have taken as per the tumor disease. The tumor was stage 4 as per the patient's all right from the beginning, and the patient's functional status of the patient was very poor. So in these two conditions, we can come to assess the patient condition. If you go by stage 4 disease, the life expectancy, what we see on the patient was nearing about 3 to 6 months. 3 to 6 months, what we thought, considering this patient condition. But once the patient came with a tracheal fistula, poor patient, life expectancy was very, very poor, sir. No doubt, sir, as option that comes to your mind, I also give an option of nasogastric tube, but really requesting that we can pour some internal drainage. It's very acceptable for the patient, and patient has a good financial status, so we thought that we can able to do it all.
Yeah, Dr. Ajay Kumar, you can come up with suggestions and comments.
I think both the patients are very well-managed patients. Let me take up the chairperson's question of life expectancy. We keep on assessing 1 month, 2 months, 3 months. The fact is that we can't be absolute about that. These are all relative. But the more important thing is the quality of life.
Exactly.
Whatever time is left of the patient's life, the quality of life actually definitely improves with these maneuvers. That is one. Secondly, whether to do it or not, it all depends upon the socio-economic criteria. At the same time, the patient's family's acceptability or patient's acceptability, how far they want to go for it. So it has to be a very individualized approach rather than on a, we can say, life expectancy this much and this. Those are all theoretical issues. Now, my only, I think I will just reiterate what Dr. Mukhevar said. I think in our practice, what we do, I mean, the last slide, which mentioned, the pulmonologist mentioned about the last slide, that some centers like to be proactive. I will say we at our center, we like to be proactive in this. We changed this approach almost 15 years back after having one mishap that we could not remove the esophageal stand and patient died right in the middle of the night. So any high-end stricture, especially malignant, we always like to go for double stenting. And we do not consider silicone stents are not easy to get, but we don't consider in a malignant patient. In a malignant patient, we'll go for a metal stent, both in the trachea as well as in the esophagus, because these fistulas will never heal. They are not to be removed. They are permanent. We have to understand that before we go for this. So benign disease, it's a different thing that we have to, and most of these benign cases that we see are related with the intubation, which was already rightly mentioned by the pulmonologist. And we have seen occasionally tuberculosis lymph nodes causing this type of fistulas. Otherwise, I think these are very well managed patients. Thank you.
Bhushan, can you show that literature's review slide? You said some. Can you show the slide again? Yeah. But I want to see the slide, Bhushan.
Can I make a comment?
Yes.
Sure, sir.
Hello?
Yes. Dr. Nikhil, please.
Yeah, so just to highlight the adverse event that we are afraid in putting the stent so high up, one is the foreign body sensation that can be intolerable. So we keep a gap of 2 centimeters from cricopharynx. Second, the migration rate is higher than as compared to the lower esophagus. So a suture material or a lasso could have been kept to keep the stent for more long time. And third is, of course, prophylactic tracheal stenting, as all the seniors have told. On the second occasion, when you had to remove the esophageal stent, I think a diagnostic bronchoscopy could have been done, and an option of ASD occluder device could have been considered, because you had a matured fistulous tract and you could have seen that a wire is passed from bronchus into the esophagus, because you are dealing with a stage for malignant disease. So you need a seal from both the sides. So stenting either esophagus or trachea would not have healed this fistula. So that could have been another option when the stenting had failed in the first case.
Yeah.
Thank you. Thank you, actually, Nikhil. It's really nice to have you here and get an
Thank you so
expert
much.
opinion on this, because we've been battling with the patient as to what we should be doing. The stent is causing tracheal compression, couldn't tolerate that. And now what we have left is a very tight fibrotic stricture, literally half a centimeter below cricopharynx. So now you can't even put a stent because that'll cause foreign body sensation on the esophagus side. And unfortunately, she's still living with a feeding jejunostomy. And perhaps now we can still try out the cardiac septal occluder as an option, which would be the best option, because otherwise it's a fibrotic stricture. There's really nothing much else to offer this patient.
Yeah, I think ASD device would help only for fistula, but not for stricture, I think.
Absolutely.
Yeah.
The stricture is, she can still tolerate orally. I mean, food is now going after the stent has been in place. It has opened that stricture. So she can tolerate it. I think it's the main problem is aspiration, because she coughs every time she drinks something. So that's something we need to fix. And on that note, we could actually try ASD closure.
Yeah, so the ASD works well for the main bronchus or the lower trachea. But in a case where there's a very proximal fistula, it would again cause disturbance with the vocal cords. So ASD is mostly kept for the right main bronchus or the left.
Maybe a smaller vascular plug of 14 millimeter, not the bigger ones.
Yeah, I think we'll really go back and do another
Review,
sort of
right. That's why
evaluation.
we
on
thought
that,
we can
actually.
do some review, some endoscopy.
Yeah, Bhushan, your slide of literature showed 78% 5-year survival. So I'm not worried about it.
Sir. Because I also worried. Same thing when I read, sir. 1 year survival, 80%, 2 year survival, 80%. So I was going into what type of 35 patient he has taken for. So they had taken a patient, most of malignant, no doubt. It was a malignant. The most common indication of bilateral stenting was an esophageal malignancy with tracheal fistula or some tracheal malignancy causing some sort of radiation stricture, something. I was really not very happy to see for the patient's point of view, but having a very good. You pointed a right way. I got the same doubt, sir.
No, but actually, when you talk about this type of a survival,
Yeah, sir.
the fistula has occurred after the patient must be tumor free at that time. After the full treatment, after radiation
Yes,
and all that.
maybe, sir. Maybe
that's
we will
the situation.
may defend that way. Yeah, sir.
So, will you see that means all the patients of upper esophageal cancers who has got stricture malignancy, want to put a tracheal stent in advance, or how you define when to put a tracheal stent in these patients? Means how much should
Yes.
be the luminal compromise or something like that on a CT or a bronchoscopy? How was the bronchoscopy in the second case, whether there was that tracheal compression?
Yes, sir. There was external compression. And in the second case, what Dr. Mukhevar was majorly worried was if we go with an esophageal stent, we might have a catastrophe on the table right itself, since there was a mass which would then completely compress the trachea. So there's no literature which mentions how much percentage of lumen compromise is an indication for stenting. But every patient, there's no one size fits all. It's a very tailor-made approach for individual patient. We have to take a call. Should we go for the tracheal stent first, or should we go for the esophageal? There's one school of thought which says you have to stop the leak at the site of leak, which is the esophagus. And there's one school of thought which says you need to first secure the airway, because we don't want any catastrophe with the airway. So for individual patients, we have to take a call accordingly.
I revert the same question, sir, Mono sir. So like what patient? But as per the newer guidelines and expertise that people are doing, as you are mentioned, it's not like for mid and lower is no doubt. For a patient having a upper esophageal malignancy stricture, it's better to get a prophylactic bilateral stenting, sir. Nothing like that. I don't know of your personal experience, but slowly according my experience, I can see that bilateral stenting works better. Not like only taking care of only esophagus. It's better to put a tracheal stent and the esophageal stent simultaneously for upper esophageal malignant stricture. Yes, sir.
There is no compression.
Yeah, sir. Sure, sir.
Dr. Bhushan, in your first case, what was the cause of tracheal fistula? Was it because of malignancy or was it because of
That's it, sir.
dilatation?
I was also very surprised. We all surprised. What is it? Why the stricture has developed? Why there is
But
no drug I
fistula,
want?
I am talking about the fistula, tracheal
Yeah.
fistula.
No, actually,
Okay.
he had
Yeah,
a
perforation.
perforation.
The first patient has a perforation.
Yes, but perforation was below also. There were two
What about the
perforations, I
same
think.
length, sir?
You
it was
said
like
it's
15
about
centimeter.
30 centimeter below,
No,
and
sir.
it
No,
was
I-
again.
You're getting.
Sorry, I'll just help you. So the
Yeah.
perforation was just below the upper esophageal
Yeah,
sphincter. And when the scope was advanced into the perforation, it seemed like the esophageal lumen. I was doing the case and I put it in and I was like, this is esophagus. I could not find the esophagus itself. So ultimately I said, Bhushan, why don't you try? And compliments to Bhushan because he managed to find the esophageal lumen, which was actually a bigger challenge for us because everything was going inside the perforation. So he found out the esophageal lumen. Then I said, great, just secure it, get a nasogastric tube. Then whatever we need to do, we can decide cervical stent, etc. So perforation was just below the upper esophageal sphincter, and that ultimately healed into this fistula. That's the
Okay. And what about the last follow-up of that first case?
Yes, sir. Just last month only we put a PEG tube, sir. Last month only we put a PEG tube in the month of, just in the follow.
In your description, you said that when you try to do the endoscopy,
Yes.
it went in the mediastinum.
We
So if it
thought-
is a tube fistula, then how do you say it went in the
Yeah,
mediastinum?
sir. It was very subjective feeling, sir, what I thought. It was not like my guide was
But
kind of
if,
stuck.
if
It may
there
be
is a fistula, then
submucosal tunnel
your
like of
scope
thing.
can
Yeah.
enter the trachea rather than the mediastinum.
Yeah.
So
it
you
may-
said it entered the
Yes,
mediastinum and then
maybe my interpretation of that may be a wrong in that when I said it. But it same feels something to me. It is somewhat in my esophageal area. It is somewhere it not outside of esophagus. That is only that may I want to say to you in that way.
extra esophageal
Extra
space.
esophageal space, whatever you call it.
no,
sir.
initially you said there was only stricture, there was no growth. And later on, when you said when the stent was put, there was a tumor overgrowth. Then
No.
Not tissue overgrowth. Tissue overgrowth.
tissue or
Tissue
overgrowth,
overgrowth.
sir.
It was tissue overgrowth.
Not tumor overgrowth.
Because of granulation tissue, because of the foreign body being there.
okay.
Sir, the first case pericardial.
Pericardial fluid was positive. See, as far as basically deciding about tracheal stent, when we find out on the CT that there is an indentation and the lumen is halfway compromised, I think that's roughly because that's better guess that it's better not to put a esophageal stent directly.
In first
Actually,
case,
the first case,
in first
the last time what happened was she came, I get a call because the referring guy knew me. He called me, he said she's coming in absolute shortness of breath and she's in Jabalpur, 5 hours away, absolute shortness of breath. BP is going down, soft blood pressure, pericardial effusion. So I said, I don't know what the hell is going on, but I said, bring her here if you can. We brought her here, moderate pericardial effusion, tapped it, turns out cytology is positive 3 years after her breast cancer. So unfortunately, metastatic disease. But it is hard to believe that 7 to 8 weeks after esophageal stent placement, the patient develops a stridor, which is unusual. I've not really seen that ever happen before. You place it and it's compressing, I understand, but 6 weeks later, absolutely fine. Comes in with CT scan showing clear obstruction of the trachea. The lumen is completely compromised. She is visibly stridor. We had to take it out. She felt better. And then at the end of it, then we said, okay, what else can we do? So we did a tracheal stent with the idea to cover it from the other side. But I think as Nikhil nicely pointed out, these are high up fibrosed fistulas, which are very hard to treat. So even the tracheal stent is really not doing the job for us in that sense. So I think we'll really have to find something to plug up that fistula.
I think you wind up.
Yeah, sorry.
Last question. The first case you said the patient had feeding jejunectomy. Then why gastrostomy?
Subsequently, after putting an esophageal stent, and prior that, we removed that FJ, sir. That's all
Okay.
that.
So thank you, Bhushan.
Yes, sir. Thank
Very
you.
good cases.
Yeah, because I mean, arranging a tracheal stent, intervention pulmonologist is more difficult than organizing a intervention gastroenterologist.
They are easy to get, sir. So let us move to the next case. Small bowel
Thank you,
big
sir.
challenges. Dr. Shubhankar Godugalle.
Good evening, all. I think we've had a very fruitful and a very complicated discussion over the last 45 minutes or so. My cases are going to be very simple. They were actually directed mainly towards my cases were directed mainly towards the residents, but I think there is slightly lesser resident crowd here. So, okay. Am I audible now? Okay. So I will start with the first case. She was a 45-year-old lady, teacher, who presented with shortness of breath on exertion, noticed in April 2024. Her evaluation was done elsewhere, which showed severe iron deficiency anemia with a hemoglobin of 5.5 at baseline and very low ferritin levels. So the patient was given 2 units blood transfusion, and then she was evaluated for the cause of iron deficiency. As her urine did not show any blood loss, the main focus was directed towards GI tract. Stool occult blood was done, and that was positive. As a routine, she underwent upper GI endoscopy, which showed lax LES, antral gastritis, patchy duodenal scalloping of folds, with a remote suspicion of celiac disease. RUT was positive. However, the duodenal biopsies revealed normal villi. There was no evidence of celiac disease. Colonoscopy was done that showed normal mucosa till terminal ileum and some small internal hemorrhoids. Initially, the patient received oral iron therapy. CECT abdomen was done, which showed mild hepatomegaly, mild bulky uterus. However, nothing contributory to the fecal occult blood positive. The patient had received H. pylori eradication in view of RUT positivity and a suspicion of RUT, the gastritis or some small erosions, giving occult blood positive test. Even after receiving H. pylori eradication therapy and oral iron preparation, the patient persistently had stool occult blood positive. So she was referred to us for small bowel evaluation. Now we come to the very basic definitions. What is overt bleeding? What is occult bleeding? So anything that we find in as in a gross bleed, like a patient presenting with hematemesis or coffee ground vomiting, the patient presenting with melena or fresh red blood in the motions, That we term as overt bleed. Whatever is not overt is an occult bleed. That means the patient presents to us with iron deficiency anemia or only stool occult blood positive. Depending on this, we classify it into obscure bleed or an occult bleed, where the source is obvious or it is not obvious. As the protocol suggests, our patient had an occult GI blood loss. So the patient, after finishing up upper GI scopy and colonoscopy, we planned her for small bowel evaluation. The initial investigation in a young patient presenting with occult blood is video capsule endoscopy. Video capsule endoscopy, as we know, was patented in Israel. It was immediately approved by US FDA in the year 2000. Capsule is a very small device of about 3 centimeters in size, which comprises of an optical dome, the vision module, that is the camera, the battery, the communication module, which transmits the signal, the sensor module, and the CPU. So this is how we apply the capsule. So the black sensors, these are basically the remote sensors which capture the transmitted data and transmit it to the central processing unit. So we did a capsule endoscopy around the level of mid-jejunum. The patient has a large polypoidal growth with superficial surface appearing to be ulcerated. And there was also minimal blood visible in the next few frames. So we proceeded with an endoscopic examination. Initially, we deliberated on whether to send the patient directly over for surgery. But because the relatives were not very keen on directly undergoing a surgical procedure, we offered them that we can try for an enteroscopy. If we can remove the lesion completely, we will do so. Otherwise, we will have to go for surgical procedure. So with this explanation, we started our enteroscopy. We went till mid-jejunum. After reaching the mid-jejunum, we found our large tumor, which looked ulcerated. It had a very, very broad base. Surface appeared to be ulcerated or eroded. Initially, we thought it to be gastrointestinal stromal tumor, that is GIST. However, the surface characteristic was not very classical of GIST. So what we did was, we tried to lift the polyp. To our amazement also, we could lift it very nicely. So the possibility of GIST was secondary. Then what we did was, we decided to snare it off completely if we can, do an EMR, basically, enteroscopic EMR. So this is how the snare went over the polyp. Just like routine colonoscopy, but since this is an enteroscopic procedure, the major challenge is that of stability. Maintaining stability in deep jejunum is a bit difficult. However, we could achieve it. So the polyp, along with that surrounding mucosa, was completely snared off, and we closed the defect using hemoclips. In total, 3 hemoclips were applied, and the procedure went smoothly. There were no post-procedural complications. Patient remained well in the ward. Then we patiently waited for 2 days. What is the biopsy report? Dr. Prajakta, would you please explain?
Okay, so on histopathology, we could see a polyp with surface was eroded. Okay, can you see the pointer? Okay. So here the surface epithelium was ulcerated, it was eroded, and it seemed to be more of a stromal overgrowth with a lot of proliferating capillaries and invaginating all the mucosal glands. So this was sort of a mixed epithelial and mesenchymal polyp. So I narrowed it down to two possibilities. That is one of the inflammatory polyp or pyogenic granuloma. It did not fit into the pyogenic granuloma since there was a lot of stromal overgrowth in the form of granulation tissue, which was mixed granulation tissue of polymorphs and lymphocytes, and they were proliferating blood vessels. So the histopathology, finally, I reported it as an inflammatory polyp, which is found in cases of repeated bouts of inflammation and repair, in cases of IBDs or parasitic infections or ischemic etiologies, and so on.
So thank you, Dr. Prajakta. So in the end, the final diagnosis of this patient remained as occult blood loss due to inflammatory jejunal polyp. When we poked the patient for history, there was a remote history rather, of long duration NSAIDs for some tooth extraction. So till now, the etiology remains unclear, but we are assuming it to be NSAID related. When we search the literature for small bowel polyps, so small bowel polyps or tumors are a rare occurrence with a prevalence of only 3% even in symptomatic individuals. There was a large European multicenter study which comprised of 5,000 plus patients, wherein capsule endoscopy was performed. Within 5,000 or odd capsules, only 129 small bowel tumors were found, which is about 2.9%. Among these tumors, most common ones were GISTs, that is gastrointestinal stromal tumors, which we had thought earlier. Another possibility was adenocarcinoma or carcinoid tumors. Secondary small bowel tumors comprised of melanomas. However, inflammatory jejunal tumors were unheard of, even in these studies. Japanese study, which had around 1,000 patients, found small bowel tumors in around 13% of the cases. However, their indication was only for suspected small bowel tumors. So, if the patient presents with occult GI blood loss, the chances of finding a small bowel tumor is narrow. It is rather rare, about 3%. Another possibilities which we could think of were myxoid tumors or something like that, but our pathologist was very sure that this is an inflammatory tumor. However, we still don't know the etiology. Then we come across a second case very soon. She is a 65-year-old lady with a comorbidity of diabetes mellitus and mild CAD who was on antiplatelets for quite a few years. She presented one fine day with acute history of melanic stools, and after a few hours, which turned out to be reddish type of stools. There was no obvious pain or loss of consciousness, giddiness. Hemoglobin, which was 11 at baseline, dropped to 7.5 after melena, for which the patient received 2 units of blood transfusion. Her antiplatelets were stopped. Upper GI endoscopy showed normal study till D3. Colonoscopy showed a large amount of melanic stool and altered blood in the ascending colon and cecum. Terminal ileum also. However, CT angiography of abdomen did not reveal an active bleed. So, in an elderly patient who presents to us with a overt bleed, our initial investigations are upper GI endoscopy and colonoscopy, which is closely followed by capsule endoscopy. When the patient presented to us in ER, the melena was rather reduced and the hemoglobin was stable over the last 24 hours. So with a moderate, and the patient had moderate cardiac risk, for which we initially thought that video capsule endoscopy was an appropriate investigation. We went ahead for capsule endoscopy. Meanwhile, we kept the patient only on clear liquids so that if needed, we can immediately go ahead with enteroscopy. We did a capsule endoscopy. While seeing the results, we came across gross amount of fresh red blood somewhere in the proximal to mid-jejunum. Now, there is always a dilemma whether to go ahead with a capsule endoscopy first or a balloon enteroscopy first. Diagnostic yield of video capsule endoscopy is equivalent to that of double balloon enteroscopy. This has been shown, rather an old study back in 2005 or 6, I suppose. However, when we performed it, however, there was another study which addressed if we perform a double balloon enteroscopy after a video capsule endoscopy, is there more yield? That study had showed that initial choice, if it is a video capsule endoscopy, that too in a case of bleed, double balloon enteroscopy at a later date results in a better outcome, in a better yield. So we went ahead with this in background. Urgent capsule endoscopy was performed. Urgent enteroscopy was performed. Initial 70-80 centimeters or around 100 centimeters, we could not find anything. There was only bile. So I was a bit disheartened that we have missed our lesion. We have lost our opportunity. However, when we went even deeper, this was maybe around 120, 140 centimeters inside, we came across a lot of blood. We went further deep and found slightly clearer area, which means that maybe the patient had started bleeding recently. When we came back, gradually explored, we found fresh blood. And as we can see, there is an active ooze, which we could see of blood. There was a small bump noted in the mucosa here. So this is likely to be a jejunal duolephoid lesion, which we very nicely clipped. The position was not very stable. So just to be sure, we placed 2 hemoclips and the oozing had stopped very nicely. I will show you the final picture. Which brings us to a very important point. The patient had an overt bleed. CT and CT arteriography, CT angiography did not pick anything. Endoscopy, colonoscopy was normal. So jejunal duolephoid lesion can be a very tricky lesion to come across. Duolephoid lesion are basically enlarged submucosal blood vessels that bleeds in the absence of any abnormality such as ulcers or erosions, which we just saw. There are the 3 main theories are that of pulsations of an abnormally large arteriole, the wear and tear of the mucosa, and third one is the age-related mucosal atrophy. Maximum studies have been done only in the gastric, so gastric are the most common. Jejunal duolephoid lesion is a very rare entity. Up to now, in the largest case series, there are 136 cases in the systematic review. There are 136 cases of jejunal duolephoid lesion. The commonest presentation being obscure overt GI bleed. Maximum cases presenting as melena or an obscure overt GI bleed. Comorbid conditions, which we mostly come across are hypertension, valvular heart disease, or congestive cardiac failure, and significantly a prior history of gastrointestinal surgery, which might have done in view of overt bleed. Hypertension, the largest case series, single case series till date comprises of 38 cases, wherein the rebleeding rate of 21% was found in a mean span of around 7 days. So this is the meta-analysis which supports that single balloon enteroscopy and double balloon enteroscopy do have a similar yield in terms of GI blood. However, the chances of completion enteroscopy are much lesser in single balloon enteroscopy. However, as I am not very well versed with double balloon, so I usually prefer single balloon endoscopy. Till date, there have been no adverse events. We come across a very short case 3, which is of a 60-year-old male with background history of diabetes since past 8 to 10 years, who presented to us with shortness of breath and anginal episodes in 2023. Actually, this was done somewhere else. Evaluation had shown a very low hemoglobin of 6.8 with a positive fecal occult blood test. The patient had received transfusion, which brought his hemoglobin up. The patient then came to India. We had a normal upper GI endoscopic study. Colonoscopy at our place showed a terminal ileal stricture. Scope was not negotiated beyond. So we did a CT enterography. In CT enterography, I think we will be able to appreciate hyper-enhancing and thickened jejunal loops and a long segment terminal ileal stricture. Is the pointer visible? Okay. Terminal ileal stricture. So we proceeded with colonoscopy. In the colonoscopy, we could see a tight ileal stricture, which was fibrotic. We dilated it using CRE balloon. We went across. However, there was another stricture, and on transillumination, we found out a third long segment stricture in the terminal ileum. So we aborted the procedure there. We did an antegrade enteroscopy in order to ascertain the jejunal thickening etiology. We found that there were multiple large diverticulae. There were multiple partial strictures with superficial ulceration and many aphthous ulcers. We took multiple biopsies. The biopsies showed chronic changes with lymphoplasmacytic infiltrate. There was villus distortion and pyloric metaplasia. So on further history, this gentleman gave a history that his son also has ulcerative colitis. So we were on the track of diagnosing Crohn's disease in an elderly male, which presented to us for the first time at the age of 70 years, which is itself rare. So this is Crohn's disease, Montreal classification A3, L1 plus L4, that is ileal and upper GI involvement, and behavior in terms of stricturizing. Occult bleed due to small bowel ulcers was diagnosed. We started the patient on budesonide. Till now, he is doing well and transfusion free, yet to follow up with us. So the take home points are obscure GI bleeding is a difficult thing to manage because of varied etiologies depending on the age, comorbidities, and presentation. In most of the cases, video capsule endoscopy remains our first choice unless there is a clinical history of or a clinical suspicion of bowel obstruction, where we go ahead and do an enteroscopy first. Thank you.
Dr. Nikhil, you can go ahead with the question
Yeah.
or comment.
So for the first case, did you thought of putting an endo loop because there was ulcerations and you were not sure what you are dealing with? It could have been a vascular tumor, right? So you were lucky it did not bleed. I would have preferred to put an endo loop before resection. It could have been a lymphoma, a cyst, or a hematomatous polyp, or a vascular lesion. So that is my comment on that. And we have one online question as well. Why was ileal dilatation done when CT showed long segment ileal involvement and skip lesions? This is from Dr. Satish.
Yes, sir. Most of the times, I mean, quite a few times, ileal thickening and strictures don't correlate very well. I mean, thickening, when we call it, it may be due to ulcers, it may be due to fibrotic strictures. We wanted to see actually what is it due to. That is why we dilated the first stricture. We went inside. However, there were multiple long segment strictures. So we did not do any further dilation. Only one stricture was dilated.
Okay.
Yes. Yeah. Actually, I apologize. I think Venkata had some challenge logging in, but I had to introduce Dr. Ajay Kumar. Sir has already introduced. But for the audience, start with Nikhil. Dr. Nikhil Sonthalia is a consultant gastroenterologist in Apollo Hospital, Calcutta, and he's an assistant professor and a really brilliant endoscopist who's traveling across India and Southeast Asia now, right, Nikhil, as an expert. So we are really happy that Nikhil could join in and give his valuable comments. And we also have Dr. Venkat Akshintala. Venkat is from Telangana. And he's been in the US for a long time, and he's a brilliant pancreatologist at Johns Hopkins. He's joining in all the way from the US, and his focus is in pancreatobiliary disorders. And he's doing some really brilliant work, which I saw in last DW, on generating chemicals to destroy necrotizing pancreatitis. So I think exciting work to follow. So hopefully he can enlighten us next time he comes to India. We can have him in Nagpur. So thank you, Venkat, for joining in, and then we can continue the questions for India.
Yes, sir.
Nicely managed cases. I'm Dr. Gaurav. So in the second case, you had a jejunal doliprosy. So what's your comment on doing a monotherapy of just clipping versus doing a combo therapy of injecting and then doing a mechanical therapy?
Generally, sir, the injection is preferred when there is very gross active bleed where you cannot localize the lesion in order to control or maybe reduce the blood flow. In our case, the bleeding was not very gross. I could very confidently locate the lesion and clip it off. So I have put 2 clips because of the same reason that if by chance one clip slips, we should at least have the second one in place. But adrenaline, I did not inject.
The combo therapy have superior results
Yes,
of
definitely. In
hemostasis.
gastric, yes. In small bowel,
Yeah, in both duodenal and jejunal both. Yeah. Thank you. Thank you.
Excellent cases, Shubhankar.
Well, I must compliment, with the permission of chair, I must compliment both young gastroenterologists like Bhushan, who has been with us for the last more than 5 years, and he is doing a wonderful job, mainly endoscopic stenting apart from ERCPs and all. And of course, Shubhankar, if you see doing his endoscopy, within 15 minutes, he is in the jejunum, and retrograde also. He's very fast, and he's after joining, he's done a lot of therapeutic endoscopy work. So compliments to both of you.
Thank you, sir.
So I think with this word, we should move on to the next case. We are running quite late. Thank you, Shubhankar. May I invite Dr. Saurabh for his case and expanding the role of EUS, new frontier in vascular EUS.
This is turned off. Okay. Okay, good evening, everyone. So let's see, let me just start. Also, I think just one brief update before I. So, excuse me one second. So I'll be talking about expanding the role of endoscopic ultrasound. So we'll be discussing new frontiers in vascular EUS. So EUS, I think all of you are very familiar with the technology, and now that we have really gone beyond what we used to do in terms of seeing and just taking samples to some very innovative and very interesting therapeutic work. We've presented this before, the biliary, pancreatic drainages, gastrointestinostomies, etc. But vascular EUS has also come of age, where with the help of EUS, we can access blood vessels and we can perform some sort of therapies. So I'll be presenting a very, very innovative and a very exciting case that we had the opportunity to perform. So this is a 57-year-old gentleman. He was diagnosed with cryptogenic cirrhosis of liver in 2021. Previously, he's a child C with a MELT of 28, actually quite high. He presented basically with recurrent episodes of encephalopathy. So this is sort of a timeline for all of you to see. 2021, before he was seen by us, he had 2 episodes of encephalopathy. He was admitted elsewhere. In August 2022, when he was initially seen at MIDAS, he had encephalopathy, very high ammonia, 223. 2 times again, late 2022, October 2023, again encephalopathy, again May, and then again June. So now he's had at least 10, if not more, admissions with encephalopathy. And if you ask him questions, you sort of realize there's a certain pattern to his encephalopathy. And for all of you gastroenterologists, we assess for constipation, non-compliance with meds, some sort of infection, electrolyte imbalance, by and large being the more common reasons. And it doesn't happen all of a sudden. His family describes that he's a businessman. At midnight, there was an event. He's distributing money to his vendors, and within 2 minutes, he's out. I mean, he's just literally talking, being very coherent with his vendors, giving money, calculating, and within 2 minutes, he suddenly loses consciousness. So it was a very peculiar pattern of his encephalopathy, and he was started on lactulose, rifaximin, branch chain amino acids, and he did not have any improvement. So a CT scan was performed, and I'll just show you the brief little video of the CT scan. And what you see here on the screen, excuse me, can I get a pointer? इधर कैसे करना? I don't know if. Yeah, no, very experienced Dr. Paranspes pointed out the right thing. Yeah, so this patient here, okay. Sorry, yeah. How do I need to take this off. Okay. So this is a kidney. This is the renal vein. This is a conglomerate of vessels. And this is the splenic vein. And this patient essentially on the right of the screen is having a shunt, okay, communicating between the splenic vein and the renal vein. And this is essentially a splenorenal shunt. So what's going on is the blood flow from the splenic vein, which is meant to go towards the portal vein, is now being shunted off to the left renal vein. And therefore, all the detoxification that your cirrhotic liver is going to perform is not happening. And all the flow from the superior mesenteric vein also is sort of making its way here. And therefore, all that flow goes into the systemic circulation and patient develops encephalopathy. So based on investigations, when the patient came to us, had some anemia, hemoglobin of 9, platelets were about 65,000. Bilirubin was elevated to 5.4, a little high. In fact, 2-3 months back, it was lower. So this had increased now. INR was up to 2.3. Electrolytes were fine. And upper GI endoscopy essentially had eradicated varices. So now at this point, this patient has had at least 10 to 15 admissions, multiple episodes, and has a shunt. So what can we offer this patient? Now at that high MELD score, we suggested a liver transplant. The patient really categorically denied, absolutely not interested in transplant. So he said, okay, then we have to consider occluding the shunt. So when it comes to occluding the shunt, there is a standard technique with the interventional radiology who can go in through the renal vein, systemic circulation, and occlude the shunt. Or in this particular case, because of his financial constraints, we said, okay, we can offer you a more cheaper option, which is with EUS, endosonography guided occlusion of the shunt. So I guess most of you, this is probably not even shown in conferences. So I think something new for everyone. So this is, let's see, I think, let me change this to this. Sorry, 1 second. Yeah. So this is what we are looking at from the stomach. And you can see what we are looking at here is basically the shunt. Now you can see that it is actually very close to the stomach, right? As you would expect, it's between spleen and the stomach, and we can see the shunt we clearly visualized. Now we want to get flow velocities, and in this particular instance, when we get the flow velocities, the patient had about 20 centimeters per second of flow velocity in the shunt, because we are occluding it. So therefore we want pre-occlusion velocities, which is what we are doing here. So this is the shunt, and you can see measure the velocity. It's about 20-25 centimeters per second. And then with the help of EUS, we can trace it, we can find its course, and then we can see that it is exactly what we are dealing with is going into the kidney. And I'll just show you at the 6 o'clock position is the kidney here, right? So this is the left kidney at the bottom,
And then you can see the renal vein and then the shunt coming all the way from there, connecting to the splenic vein and the spleen, which is now here on the screen. On the right of the screen is the spleen. So you identified the structures, measured the flow, and then what we do is found a very suitable access point. And then this is, I'll just show you for a moment. So as we go from the stomach, this is a very suitable access point. It was a bend. So the idea is that when you're coiling these areas, you don't want the coils to get migrated out. So we found a suitable access point, and through the stomach we went in, and we are now deploying coils. So coil 1 was deployed, and then another coil was deployed right there. And then, sorry, this is ultimately glue injection was performed. So this is the coil and the glue cast that has been, that's there, and you can see the shadow suggesting that a nice complete obliteration has been performed. And now you can see the portal venous flow, and now you see the flow has now suddenly reduced. So now you can already see the flow within a few seconds going down to below 5 centimeters per second. We did an additional round of glue injection, and now distally, it's quite impressive though. Within a few seconds, suddenly the vessel lumen goes down. The flow is down to less than 2 or 3 centimeters per second. And this was a visible improvement in the flow that we could see that eventually gets obliterated. So the post-procedure, by the time we took the patient for procedure, he was although optimized, but we realized that he did have coagulopathy and ultimately ended up having hemoperitoneum because of the coagulopathy that he had. Required blood transfusions and tapping of the hemoperitoneum, following which he improved. He developed ascites. Now, we would expect that because I have closed the shunt. So now portal flow is on the portal side has increased, and therefore he's now developed ascites. So we did therapeutic paracentesis, 3 liters of fluid was removed, but had improvement in sensorium. Ammonia levels you can see from 5th June, the day the procedure was performed, to the most recent one on 20th August, you can see a consistent decline. Although ammonia levels are not absolutely some things we monitor, but just for you to illustrate, you can see a reduction in the ammonia levels. And this is the post-procedure CT photography. And then you can see across here, this is the coil, and the shunt is practically gone. There's in fact a separate collateral next to it. But you see here, this area where the shunt was is like practically collapsed. 8 weeks later, which is basically yesterday, over the course of 8 weeks, he had one episode of very transient encephalopathy, but really nothing, and he was doing extremely well. Bilirubin, thankfully, has not gone up. Initially, we were concerned, but pre and post procedure, it's sort of low. In fact, actually less. Ascites, not much. He's requiring once a week diuretic dosing, which is practically prophylactic doses. So, so far, we have been very happy with his progress. We'll see how he does in the future. So if you think about hepatic encephalopathy, we are looking at 3 main reasons: acute liver failure, portosystemic bypass, which not exactly this patient, but can be spontaneous in other cases, and cirrhosis, portal hypertension with or without shunts, which is what the patient has. So these patients can come with persistent encephalopathy or recurrent encephalopathy. So our patient had recurrent encephalopathy. And generally, if you think of encephalopathy, you think of all these precipitating factors, but they were basically ruled out in our patient by and large every time he was admitted. So portosystemic shunts was the reason why he came in. So clinical features wise, these shunts by and large present with recurrent encephalopathy. The gastrorenal complex of veins can then ultimately have gastric varices and bleeding. But if you look at the shunts, so on the left is a splenic vein giving a conglomerate of gastric varices and a gastrorenal shunt. What our case had was more like on the right, which is splenic vein and then a long shunt towards the left kidney, the left renal vein. So this was a splenorenal shunt for this patient. And this is essentially how it looks like. The left of the screen is the image which I showed you earlier. So what is it like really? The shunt is like spontaneous TIPS, basically. So TIPS, you do it for treating portal hypertension, create a shunt, which reduces your portal hypertension related issues like ascites and bleeding, but the complication can be encephalopathy. On the other hand, splenorenal shunt is like a free TIPS that the patient has got without paying for it. So it's working, reducing portal pressures, but now we are dealing with a problem from that, which is encephalopathy. So when should you be doing shunt embolization? Now we don't see this very routinely. So there's a classification. So when you have SAD A, which are asymptomatic cirrhotic patients, no reason to do any intervention. SAD B, patients have overt episodes of encephalopathy. These are the ones ideally the ones you should be doing shunt occlusion. And SAD C are the ones who have hepatic failure and shunting, which is leading to persistent recurrent encephalopathy. These ideally should be undergoing liver transplant, but because of various reasons in our case, we decided to still take the patient up for shunt occlusion. So if you look at the data, this is the first study. This was published, I think, in 2013, where they looked at embolization of these large spontaneous portosystemic shunts for refractory hepatic encephalopathy. And this is a hepatology paper. You look at left graph. Now, 100% before embolization. After embolization, overall, within 100 days, 40% still had encephalopathy. So it's not perfect because of patients may have parenchymal failure. So the ammonia detoxification still may not take place from the liver, but an overall about 50% success rate based on the study. On follow-up, number of hospitalizations had significantly reduced. What can be done with our IR colleagues? They do this in various ways, the BRTO, the PARTO, the CARTO, essentially going from systemic circulation and occluding these shunts. And this is the overall data now after multiple studies. And Phillips, which is Abby Phillips, has published a very nice study. This is 45 patients, a large study with IR techniques, and then overall 4.5%. So quite impressive, much reduced recurrence rates. Lin et al., 92% no encephalopathy. So worked quite well. 60, 90%. So we are anywhere looking between 50, 60% to almost 90% success rate in terms of reducing encephalopathy in these patients. So by and large, patients who do really well are the ones whose liver is parenchyma is not that badly compromised. So low MELD, I would say not even 11, up to 15 you can go. Less than 15, large shunt, they'll do fine. When it goes above that, there's a higher risk of problems and complications. So what you do expect is a lot of portal flow. Blood flow increases because the shunt is blocked. The synthetic function actually surprisingly has been shown to improve, maybe because of increased blood flow to the liver after shunt occlusions. And most recently, and we were really happy to have Dr. Sarj Rathi, who was visiting us, and then he was there in the room helping us with the case when this case was performed. So he has been innovative, and he's from PGI Chandigarh, and he's published the first series of this, and he's practically the first person doing it. So these are his cases. He's done about 7 patients, and overall significant improvement was seen with the help of EUS in all of them. One patient developed retroperitoneal hematoma. Some had self-limited fever, but no other major complication. So overall, if you see, it seems to be a very promising option for these patients, and can be much cheaper because it's almost 1/3 or 1/4 of the cost that they would have to otherwise with the help of interventional radiology. But again, we need to make sure that the patient doesn't have coagulopathy because you're puncturing a vessel. So that's something that you'll need to be careful about. But low MELD patients, this is a wonderful option. And we are actually part of the International Now registry. So certainly we are happy to help and contribute now to this registry, which is then ultimately going to be published. Let's see. And I would like to invite all of you for the MIDAS liver meeting. This is going to be a midterm INSL meeting with a focus on portal hypertension. just like the case I showed you today. So this is 18th and 19th of January. We are expecting 5 or 10 international speakers and some brilliant national speakers as well. So please block your dates and we'll have a brilliant liver meeting in January. I'm happy to take any questions. Thank you.
Congratulations, Saurabh. Excellent case. I have one question. You described typical pattern for encephalopathy. The patient is very well at and in a moment he deteriorates into the abnormal behavior. Now, this pattern is not typical of encephalopathy. This pattern is typical for a epilepsy or a vascular episodes.
True.
So, did you really try to rule out epilepsy by doing EEG before you undertake occlusion of splenorenal shunt? Because anyway, you will get splenorenal shunt in almost 10% of cirrhosis. So,
True.
it may be just a coincidence that it is there.
No, yes, I think she had CT scan. I should have mentioned CT head was normal, and the neurology consultation was also done in the prior admissions where it was not felt to be epilepsy. I have to see if the EEG was specifically performed, but thanks for pointing that out. But considering the cirrhosis patient, ammonia levels being high, shunt being visible, clinical pattern, we did not feel strongly about doing EEG. CT head was done to rule out any neuropathology though, yeah.
In fact, I must tell you that the diagnosis of shunt was done. The patient's liver function that time was very well preserved. So clinically, we thought that why these patients' bilirubin is good. This I'm talking about is 2.5 years back, because he had 8 to 10 admissions. So first time, then this bilirubin was good, albumin was good, and he was going in encephalopathy. So that was the reason that clinically we suspected that this could be a portosystemic shunt. And when we did, there was a big shunt, which was already diagnosed 2 years back. Patient was not, that time when the patient came to us for the first time and his ammonia was high. So we thought that we should give him, optimize the medical line of treatment, and in case he has recurrent bouts of encephalopathy, we should offer him the vascular intervention. In fact, we've been awaiting for this vascular intervention for the last so many days that we should have a suitable patient for vascular intervention. And in fact, I must compliment Saurabh for doing it bravely, in spite of the platelet count being 60,000. Fortunately, patient could be, he had bleed, he had a little post stomy course, but ultimately he could be salvaged. And I was most happy when he came yesterday in the OPD and they literally touched our feet. So that sort of satisfaction, because he's now back to his work and the quality of work is very good. And subsequently for the follow-up of, I think, 2 or 3 months, 2 months now,
2.5.
he does not have a single episode, which he was getting almost, he was getting hospitalized once in a month.
Congratulations, Saurabh. Now with blockage of the shunt, the chances of increasing the esophageal varices, maybe again the congestive splenomegaly, hypersplenism. So this, I think the chances will be more as the shunt has been blocked. So what is your
No, that's a valid point. And that's why if looking at the data, we are looking at a 20-30% increase in portal hypertension related issues. So it's not 90%. We are 20-30%. In our patient, fortunately, the bilirubin has been fine. Ascites wise, really not bad. He's had eradicated varices, but perhaps a good time now would be to see and assess whether portal hypertension has led to increasing in the pressures. But since it was all scarred down, we are not too worried, but yes, we should be assessing that right now. Yes.
Sort of just a couple of points on the technical aspect. The site of puncture that you chose, I think you could have chosen a little bit of cushion of pancreas or a parenchymal structure, because that could have given a tamponade. You had a little bit of hemoperitoneum. And the second point, how did you calculate the size of the coil? For variceal bleeding, we calculate as 120%,
yes.
Right? So in the target is not a complete obliteration, but the target is to prevent embolization of the coil.
Yes.
So in this was a large shunt of maybe around 20 millimeter, right? So how do you calculate the size
Yeah.
of coil and amount of glue?
So
And
the size, no, thank
Yeah.
you. So yeah, anything else? Yeah.
Yeah, just one more point. There have been anecdotal reports of doing a traditional venography because
Mhm.
these patients have additional collaterals, they have additional pericardiopenic shunts. That is why the technical success does not translate into 100% clinical success. So it is recommended before IR, all people also do, they do a proper anatomical evaluation of the venous collaterals and then they embark upon this. But for US, we are just starting doing these procedures. So to get more clinical success, I think you should take a opinion of IR people regarding the anatomy and additional collateral and shunt that may increase after blocking of this large shunt. So what are your comments on
Yeah.
that?
No, I think good comments. So the first one was parenchymal cushioning. Yes, makes sense to have parenchymal cushioning, but the fact is in this particular instance, it was not possible to have it because there's really no option to reach the shunt, having the pancreas as a cushion. So therefore, we had to go freehand where the location was. The size of the coil is based on 30% more than the diameter. So I'll have to see exactly what the diameter was, but I think we use a 16 mm coil. It's about 12, 13 mm must be in the diameter. I'll have to go back and see that exact number. But we use a 16 millimeter coil. So this coil size was 30% more, which is pretty much what we choose. And I think you make a valid point that there can be more than one collaterals. There can be more than one shunts. The situation is with US, you cannot get a great venograph because of the needle size being small. Also, the IR, yes, it's a certain advantage because you can occlude it, put it with pressure to opacify the shunts. With EUS, even if I would put contrast, it would not flow through those smaller collaterals because the sheer volume of this flow will preferentially go through this large shunt. So, and in fact, I agree with you. In this case, after occluding it, we could see a little small sort of shunt next to that, which wasn't visible before because the flow was absolutely zero in that. The flow was mainly going through this. But it's not clinically causing any problem right now and makes sense. That's probably two reasons why they may still not have 100% success. One is, as you pointed out, some other shunts which open up, and two is the parenchymal failure. So now the liver and the behavior of the liver then can determine the failure rates. But yeah, valid points. I think that is a certain disadvantage to determine the rest of the vascular anatomy. But I suppose if you have a large shunt, you address it. Small shunts is there, will be there, and there will always be small shunts in these patients.
I don't think it is still a standard of care. It could
Yeah,
be
no, I agree.
alternative options. Yeah.
Excellent demonstration, Saurabh. So just wanted to ask one thing, whether the time has come, we should start thinking of EUS guided intervention as the first option over IR?
No, I think somewhere in some instances it is equal or financially, economically more viable. For instance, gastric varices, you can do it, it's cheaper than doing a part 2 or something, right? Although I think IR interventions are brilliant, work very well. But in some instances, we are good. Other instances, we should not be putting our hands in. So if it's a really massive, large gastric varices, it's better the IR does it than we do it because we are not doing justice in that case. So I think it's a case-by-case basis where some instances US is good or better, and in other instances it may not be. So for example, hepaticogastrostomies are fantastic with the US. So there's really no, and or CDS. You don't really need IR intervention if you can do it properly. But some of these vascular interventions can be plus or minus depending on the case. So you have to be cognizant of which case you do with the US and take the appropriate precautions. Yeah.
Dr. Venkat, want to comment?
Yes, a quick comment. Sort of beautiful case, and you showed how we can take advantage of EUS. And we at our institution even try to do tips with EUS.
Yes,
but the limitations, some of the limitations are just as you pointed out, the accessories that we have. And as was alluded before, the embolization and such other risk, because unlike IR, our accessories are limited in managing it and also managing the complications. But again, you pointed out the balance that we can have and how we can still help out.
Yeah, I think I did come across the video from 2008 from Hopkins in the big model when you did a US guided tips, which is a pretty impressive thing, but it's big. So yeah, thank you.
Thank you, Saurabh. Now, no more questions or comments? Yes, Ravi.
Hepatic encephalopathy like this patient had for last 2 years, there are methods which we can use to pick that up in the early stage as well, like something called Stroop test, which is I think by Dr. Jasmohan Bajaj. There's an app basically. Other are number counting tests and many other tests are available. So I think it's a time that now that we are intervening as well, we can pick them up early, and maybe early intervention can help us maintain or make these patients live a better quality of life for longer duration.
No, you're right. Because I think the encephalopathy is not really picked up to the point. Cognitive decline, then what we call as minimal encephalopathy, which is not clinically overt, but there's subtle encephalopathy going on in these patients, which, with these tests, which we can determine reduced cognitive abilities. And there's so many things that are going on in these patients, which are not picked up at all. We wait for that patient to be in ICU to call it encephalopathy.
Exactly.
But what they're having is on a daily basis encephalopathy.
Yeah,
Thank you.
Thank you everyone for all the nice comments. Very nice case, Saurabh. We move on, and next on agenda is introductory remark by Dr. Srikant Mukhya.
Introduction. Thank you.
Hello. Well, it's extremely happy occasion for me to announce that we got this time also in the South Korea World Cup of Endoscopy. Saurabh won the Best Endoscopy Award for the case which has been selected and which is going to be presented here. And in fact, couple of years back in Tokyo, Japan also, he got the Best Endoscopy Award for the luminal category in the procedure called as PRAME, rectal endoscopic myotomy. And in the gallbladder category also could get the award for transdural gallbladder drainage. So transdural gallbladder drainage in a non-distended gallbladder in an 80 years old patient. So we must compliment him and offer your blessings to him that he will continue to make the Nagpur and India proud. Thank you.
Congratulations, Saurabh. I think now you have to present that World Cup winning video. We are interested to see.
This is fine. Hello. Mahesh. Hello. Okay. So, right. So this is the case which we presented recently at the endoscopy meeting in Seoul. This was EUS guided duodenojejunectomy for a patient with afferent limb syndrome. And just I think we have presented something similar in the past in our clinical meeting forum. Afferent loop syndrome is basically a mechanical complication that occurs after patients with surgeries and anastomosis involving upper GI tract. Can be any intrinsic process or an extrinsic process that's causing the obstruction in the limb. And the most common causes include adhesions, internal hernias, or recurrent disease, like, for example, the cancer. So we'll talk about the case here. I'll be keeping it very brief in the interest of time now. Yeah, so 57-year-old female presented with recurrent vomiting, jaundice, fevers, and chills. She had a history of hypertension, diabetes, and an ampullary cancer post-pylorus preserving pancreaticoduodenectomy 2 years back. This was actually done at MIDAS itself. She had received 8 cycles of chemotherapy following her surgery, but then she presented now with anemia, leukocytosis, mildly elevated AST and ALT, and bilirubin elevated up to 9.4 with low albumin levels. And vitals, she was in shock when she presented, room air 96%, and then she was admitted in ICU. So basically, this is a lady post Whipple's, now with jaundice, shock, vomiting, fevers. And this is a CT scan that was obtained, and you can see this is a dilated jejunal afferent loop, which is there connected to the liver. And inside the liver, you can see these multiple spots, and these are cholangitic abscesses in the patient. So this is basically sort of the illustration. And on the left is the afferent loop with dilated intrahepatic biliary radicals and multiple cholangitic abscesses. So we discussed options, but surgical management with the patient being in shock was not really a viable option. Interventional radiology with percutaneous drainage versus endoscopic ultrasound guided decompression of the afferent limb was considered. So this is basically what we aim to achieve, is the connection between the duodenum and the dilated afferent limb of the jejunum. So this patient, bear in mind, was having shock, so we didn't have much time. We could not give any prolonged anesthesia to this patient. And here's the scope being advanced into the duodenum, and you can see there the suture line that from the prior surgery. And now we could identify the dilated jejunal limb quite well. This is the tube that you can see that was placed during surgery into the limb, which actually confirmed that we're in the right location. Found a suitable window. And now we are advancing the cautery-enhanced lumen-opposing metal stent. This is the Axios, which I'm sure all of you have seen in here being presented before. This is a 20 millimeter stent that we've deployed. You can see the stent being deployed there. And yeah, so this is from the duodenum side. Now we can see the duodenojejunostomy. This is being created with a gush of bilious fluid that's seen coming out right there. So that's the illustration there. So post-procedure, this patient fortunately did very well. The bilirubin reduced from 9.4 to 2.2. Fever subsided. She was just out of ICU, shock improved, and practically in next 3 days, she was almost discharged. And 6 months later, she's had no recurrence of symptoms and is doing well. So afferent limb syndrome presents with vomiting, abdominal pain, and jaundice. EUS-guided enteroenteral anastomosis with these stents is successful, more than 90%. And adverse events are infrequent, less than 10%. So it's a feasible and effective management for afferent limb syndrome. Happy to take any questions. Thank you.
Nice case, Saurav. I was there with you when you won the prize for this. Just a couple of questions. I would have preferred to put a 15 millimeter lamps because the aim is only to drain the bile and not allow the food go into the afferent limb.
Yeah.
Second, you could have, did you search for a window from the stomach? Because you don't want that opposite duodenal wall to be eroded with the stent flange, right? Because 20 millimeter flange has 2.5 centimeter. And there's always a possibility of entrapment and erosions of the opposite duodenal wall. So I would have looked for a window through the stomach instead of duodenum if feasible. And you had a tube inserted in the limb. So did you not consider putting contrast mixed methylene blue saline for more confirmation? Because you could have accidentally punctured the downstream area as well, right? So a real-time installation of contrast with methylene blue and paralysis using a glucagon that will follow for GJ. Did you consider that? Any comments? Yeah.
No, thank you. I think the tube was actually placed during the Whipple surgery. Dr. Naikwade did the surgery, so he can comment on the reason for placing the tube. But that was not something we could access. With regards to the window from the stomach, there were vessels, so we could not get any suitable window. And this was really the absolute only window that we could find was from the duodenum. But yeah, I think you made a valid point. Smaller stent could be better. perhaps even a 10 mm stent would, I think, would serve the purpose. So yeah, I think in hindsight, we could have chosen a smaller diameter stent. But yes, these gastric window was not feasible in this case. Yeah.
Thank you.
Yeah, wonderfully managed case,
Thank you.
Saurabh. What was the cause of afferent loop obstruction in this case?
Yeah,
What is the
that's the
adhesions
point.
or recurrence or something like that? And where was the obstruction means to the afferent limb?
So in the scan, we could not determine exact site of obstruction in terms of the distance from the duodenum. And we didn't have much time. I mean, there's really not much time for us to assess where that is and potentially do it. But you make a valid point. Assessment of the exact site, potentially looking at maybe if it's a kink, that's fine. But if it's a recurrence, then it should be addressed. So at this point, we just wanted to get it done with and then come out as soon as possible. So she was on shock and 5 of NORAD when we did the case. So.
Stents or plastic stents, can these enteral stents or plastic stents can be put across that stricture?
Yeah, not true. If you have time and you can reach the axis, then maybe, but I guess, yeah.
What we usually do, we do hepaticojejunostomy and pancreaticojejunostomy rule. We brought it down through the ligament of treats. So it's anatomical location. So sometimes it may stuck up at that point. So that is the point of obstruction. And that's why that efferent limb was dilated. And I took another limb for the duodenojejunostomy for food. So that's why he was very well able to cannulate these two limbs. So that's why only PJ limb was obstructed. And another question by pancreatic stent. So most of the time during periampullary procedure, we get a pancreatic duct of size less than 6 millimeter. So what we do, just insert feeding tube of 8 or 10 French, so that while taking sutures, we should not inadvertently obstruct the pancreatic duct. So most of the time that is passed off in the feces after say 6 or 10 months. But sometimes these cases occur that it retain there for lifetime and doesn't occur anything. So they are there to locate that pancreatic stent.
I think jaundice would occur only if there is hepaticojejunostomy.
Yes.
In other cases of afferent loop, I don't think jaundice will occur.
No, if there is hepaticojejunostomy, they'll have jaundice. But typically, these are the ones who have hepatico J and Ru and YSO configurations. So there's a obstruction below. It's true.
I think very nicely presented. Very good case. Next case is to be presented by Dr. Srikanth sir, a rare case of colitis.
Well, I'm going to be short. I have to be short. This is a story of a 56-year-old male who presented to us very recently in the month of June. He had type 2 diabetes, hypertension. He was on Glimda, MB and Telsar. Diagnosed to have chronic myeloid leukemia in 2021. Initially was put on imatinib, and because the load was higher and the disease was not under control, he was put on dasatinib 100 milligram since December 2023. He had painful defecation, which was possibly because of the fissure, but also had loose motions mixed with blood and mucus for 12 days with fever, loss of appetite and weight loss. He was evaluated outside and was by a gastroenterologist and labeled as ulcerative colitis on colonoscopy, but was given steroids and had no response. Hence, patient attended MIDAS. He had fever of 100, heart rate was stable, BP was good. The anemia, hypoalbuminemia, CRP and ES are elevated. His fecal calprotectin was negative. It's not calprotectin. The fecal stool C difficile was negative. Hepatitis HIV was negative. Ultrasound showed a mural thickening in the left side of the colon, hence colonoscopy was done and the biopsy sent for CMV PCR. Histopathology was severe active colitis. Somehow when this procedure was going on, I felt that this is not a usual type of ulcerative colitis. I can't describe what it was, but when I had taken the round on the next day, the first thing which I thought that this is something different colitis. So we went ahead with the history of the patient, that what was he on, and so then later on we found out that he was on dosatinib, and by the time the histopathology had come, which only suggested colitis, the first thing when we Googled dosatinib, does it cause colitis? It said yes. So the first thing was to stop the drug, and patients received injection hydrocortisone, suspecting that it was ulcerative colitis for first day only, and then it was stopped. And fortunately, after stopping the drug, his symptoms recovered within a period of 2 to 3 days. After 3 days, when the CMV load was there, the CMV was 2146 IU per ml, but the histopathology did not show any evidence of CMV colitis. Valganciclovir was given because he was immunocompromised, so we thought that this is a bystander infection, continued for 21 days. I think I should involve Prajakta because she was the one. So there were 3 possibilities here. Patients with CML have more chances of ulcerative colitis. So it could be ulcerative colitis in a patient with CML. Second, it is a dosatinib-induced, drug-induced colitis. And third, it is the last possibility, which I think is HSV-induced colitis. However, I'll get the opinion of Prajakta.
So the extent in this case was again from the rectum till I think sigmoid colon, right? No, we did not. Okay, so considering the clinical possibilities of all these 3, ulcerative colitis versus drug-induced colitis versus CMV colitis, histopathology showed minimal to mild distortion of the crypts, which was going against the diagnosis of IBD. There were crypt abscesses, active inflammation, and crypt loss, which suggested a slightly a longer course of the disease, a little bit not that chronic as it is in the IBDs, but slightly less course of a disease. So in between acute and chronic. And the possibility of CMV colitis was ruled out. It was negated based on the absence of findings of the CMV viral cytopathic effects, which are typically the cytomegalies, nucleomegalies, and viral nuclear inclusions, which is the typical owl's eye inclusions. So these were not seen on histopathology. Neither they were detected by IHC. However, the PCR, which is a more sensitive test than histopathology and IHC, it came out to be positive with a viral load of more than 2000 international units. Based on the clinical findings and on the histopathological findings and going through the literature, I narrowed it down again to the two possibilities. That is, it could be IBD, early stages of the IBD versus drug-induced colitis, and the clinical judgment and the clinical findings and everything taking into picture. Close monitoring was done, and sir will explain.
Thank you, Prajakta. So basically, sometimes drug-induced colitis is very difficult to diagnose because you need improvement after the cessation of the drug and sometimes re-challenge, which is practically not ethical. But I was just going through the literature that drug-induced colitis can be macroscopically and microscopically. The lesions can be either focal or diffuse. It can be involving the entire colon. In this patient, I think it was a limited examination done. So in the report, it was written as sigmoidoscopy, but I think as Dr. Bhushan says, it was going till the mid-transverse colon and the entire segment was involved. It can be new onset or exacerbation of IBD. So the microscopic colitis, which is morphologically colonic mucosa, is normal. That's why the dictum is you should always have a biopsy when you suspect that it could be microscopic colitis. Lymphocytic colitis and collagenous colitis. Dr. Manoj has presented last week a case of olmesartan giving rise to lymphocytic as well as collagenous colitis. In fact, collagenous colitis. Histologically, they have more than 20 intraepithelial lymphocytes and a collagen band in collagenous colitis. So I was just going through the drugs. There's so many drugs which are responsible for microscopic colitis. Proton pump inhibitors, NSAIDs, SSRIs, AC inhibitors, beta blockers, statin. So mainly the drugs which are used by gastroenterologists and cardiologists to remember. And the patients having macroscopic colitis, the drugs which are the chemotherapeutic agents, immunomodulators, anti-diarrheal agents by increasing the colonic pressure can cause ischemic colitis. Cocaine, amphetamine, NSAID, hormonal therapies, so on. So the mechanisms is either ischemic or inflammatory. And there is inflammatory because of gold salts, NSAID, carbamazepine, and statins by unknown mechanism. So these are various mechanisms. Dosatinib-induced colitis, there is a high prevalence of diarrhea in patients on dosatinib. 6% of the patients have hemorrhage. In Japanese series, out of 45 patients, 1/3 develop colitis, and most colitis occurred within 3 months. And the mechanisms are, it reduces the regulatory T cells and NK cells and increases the cytotoxic T cells. Stopping the offending agent is the suffices in most of the cases, but some people would require steroids. So that is how I think the lesson which I would like you to take from this case is any patients with ulcerative colitis, when it presents to you, first ask the history that whether the patient is on some drugs which are responsible for colitis. And 75% of the colitis are secondary to NSAID. So NSAIDs, non-steroidal anti-inflammatory agents, are the major cause of ulcerative colitis of a drug origin. Thank you.
Sir, I remember to have heard in some previous meeting unusual colitis due to some corrosive enema also. I
Yeah.
think you had present.
Yeah. We have presented unusual colitis secondary to corrosive enema. Then we had presented cases of diverticular associated colitis, coloning diverticulum associated colitis. Then we have presented CMV colitis. So all these rare patients. CMV, of course, is not that rare. Difficult to basically morphologically looking at it, it's very difficult. It has to be by the biopsies and PCR only. So otherwise, looking at the morphological appearance, you can't definitely say that this is CMV colitis. Any comments from the online chairpersons and yeah.
Sir, there is a question in the chat box. It's from Chongo. With a typical CMV lesions on colonoscopy and positive PCR, is the viral load necessary for treatment?
What was the question you said?
Sir, with the typical CMV lesions on colonoscopy and a positive PCR, is the viral load necessary for treatment?
I think sometimes it is difficult whether it is definitely CMV colitis or ulcerative colitis. You can't morphologically be sure about evidence of CMV colitis. So getting the viral load encourages it confirms the diagnosis and putting the patient on the right treatment.
So possibly he must be talking about the tissue PCR maybe.
Tissue PCR. We have sent the tissue PCR only. This was the tissue PCR? Yeah.
I don't think there are any questions. Wonderful meeting. Thanks from all the chairpersons. Thanks to MIDAS team for inviting us for this.
Thank you.
So I really thanks all the chairperson, offline chairperson, Dr. Abhiram Paranspe sir, Dr. Vaibhav Banas sir, Amit Agrawal sir, Manoj Vivare sir, Gedam sir, and Dr. Chude sir for really chairing this session. And also the online chairperson, Dr. Nikhil Sontalia, Dr. Ajay Kumar sir, Dr. Venkata for really joining and putting their inputs. And all the speakers, all the case was very fantastic. We learned every day from this, every time from MIDAS Clinical Meet. And this 118th clinical meeting by Dr. Mukewar and MIDAS team. So now I really end of this MIDAS clinical meeting from academic point. And now we can really welcome all of you for cocktails and dinners. Thank you. Sir.